Good morning, everyone, and thank you for joining us for today's Knockout Opiate Abuse Learning Series webinar. This webinar series is a continuation of Knockout Opiate Abuse Day, which was designated as October 6th each year by Governor Murphy. And this learning series is designed to continue the awareness and education highlighted by that initiative throughout the year. Today's webinar, The Perfect Storm, COVID-19's Impact on Addiction over the Past Year, is brought to you by the Partnership for Drug-Free New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And I thank them for their partnership, support, and collaboration on today's learning activity. We have a varied and expert panel of featured speakers for today's webinar. We have Lieutenant Jason Piotrowski, Drug Monitoring Initiative for the New Jersey State Police. We have Dr. Meg Fisher, Special Advisor to the Commissioner of Health, New Jersey Department of Health. We have Caitlin O'Neill, Director of Harm Reduction Services and Co-Director of the New Jersey Harm Reduction Coalition. And we have Jenna Meller, who is Executive Director and Co-Director of New Jersey Harm Reduction Coalition as well. All of our speakers will share with us their experiences, strategies, and solutions from this past year, as together we've all continued to address the opiate epidemic and the addiction crisis in the midst of the COVID-19 pandemic. We welcome all of our speakers, but before I turn it over to them, I have a few housekeeping items I did want to address. Today's presentation will be available to you after the event. We'll have it available on the website, a recording, as well as slides. You'll get an email with all of that information on how you can access them. And I also ask that you please put all of your questions in the chat, as Greg mentioned earlier, and also note that those questions will not be addressed until all of our speakers have concluded their presentations. So I want to thank you again for joining us today. It's hard to believe it's been 1 year that we have been, in this COVID-19 world. And we started about this time last year with our first webinar. I know many of you have been with us since that time, and I thank you for that, because together we learned, different best practices that we could use to continue to address both the opioid crisis and the addiction crisis. And so now I'm going to turn it over to our first speaker for today, Lieutenant Piotrowski. I'll turn things over to you to begin.
Good morning and thank you. As we begin, I would like to thank Drug-Free New Jersey and its staff for hosting this virtual town hall. I'd also like to thank my fellow panelists and partners who work diligently to combat community drug harms. The New Jersey State Police Drug Monitoring Initiative, or DMI, commenced in 2013 by retired Major Juan Colon in response to the overdose epidemic. The DMI has been a vital tool in establishing an intelligence capacity that supports all stakeholders focused on reducing overdoses, deaths, and other drug harms. Next slide, please. The DMI program is utilized to gain a comprehensive understanding of the many complex factors composing the drug environment. Specifically, we provide an understanding of community drug harms at the state, county, and local level, recognition of emerging drug threats in real time or near real time, and most importantly, identifying the people, populations, and areas that are most at risk for overdose or death. And what is our DMI? It's essentially a multi-jurisdictional drug incident information sharing environment. It's built on multiple partnerships with forensic laboratories, law enforcement, health departments, mental health and addiction services, medical examiners, local drug coalitions, recovery groups, and many others. And how do we do this? Well, it's done through a data-driven approach to produce positive outcomes by collecting, analyzing, and sharing formerly siloed data with our partners, arming our stakeholders with the information necessary to prevent, educate, and conduct community outreach. Next slide, please. Very specifically, though, through our partnerships, what we try to do is understand the scope of the epidemic, understand the presence and prevalence of dangerous novel drugs, and enhance policies and practices for mitigation of community drug harms. Moving forward, I'm going to deliver a data-centric presentation which represents what we know about the drug environment today here in New Jersey and what we observed related to the impact of COVID so that we can all understand better what we were up against. The one thing I always like to say is that I would be remiss if I didn't stress that it's not lost upon myself or my small team here at the New Jersey State Police that when we talk about these numbers and statistics, that we are in fact talking about people, loved ones, family members, friends and neighbors who are suffering through substance use disorder. Please understand as I go through our statistics that we do not present this data lightly. Next slide, please. So New Jersey's seen an increase in the number of suspected drug-related deaths every year from 2010 to 2020, except for a small decrease in 2014. We assess that because state government recognized the increase in drug-related deaths and responded by authoring the Overdose Prevention Act and mandating law enforcement administer the life-saving opioid antidote naloxone. Unfortunately, this momentary progress was halted as the increase in presence of fentanyl class compounds was discovered in postmortem toxicology beginning in 2013. The presence of fentanyl in the drug environment and more recently polydrug substances has contributed to the significant number of drug-related deaths. We continue to lose more than 3,000 people per year or more than 8 people every day here in New Jersey due to suspected drug-related deaths. You can go to the next slide, please. Through the DMI capability and our relationships with our forensic laboratories, medical examiners' offices, we've recorded 38 fentanyl class substances identified in New Jersey. This timeline shows the identification of those substances by year, the collection of the analogs, new novel substances, and sharing of this information to the public safety and public health partners allows them to better understand the threats in the environment. You can go to the next slide, please. What we saw at the onset of the pandemic was a 19% increase in suspected drug-related deaths when comparing data from the previous year. Starting in July 2020, though, to the end of the year, every month was lower compared to 2019. That gives us a little bit of hope. You can go to the next slide, please. This slide represents a more comprehensive view by month. Looking at each month, you can see there are a lot of ebbs and flows over time. But one caveat to point out is that January to April 2019 was atypically low. So making that comparison to any other time frame is going to be skewed. Lastly, January 2021 showed a significant increase in drug-related deaths. What I want everyone to take when you look at these slides is that although we have another more pervasive public threat in terms of COVID-19, opioid overdoses remain a significant threat that necessitates attention. You can go to the next slide, please. Through our partnership with the New Jersey Department of Health, we share first responder naloxone administrations to help us understand where more resources are needed. As you can see by the graph, on average, roughly 14,000 administrations occur in New Jersey each year. While we see slight declines in first responder naloxone administrations recently, it's unknown if it's due to the COVID or if it's due to the widespread availability of naloxone, which we are unable to track. I say that specifically because the drug-related deaths, which should closely correlate to naloxone administrations, have remained steady and in fact have gone up a little bit, while the administrations of naloxone have declined. Even so, the over 14,000 administrations represents over 39 potential overdose deaths on average every day in New Jersey. Now they're not deaths, obviously, because there's about 8 per day, but the 39 administrations a day is 39 overdoses, and something that everyone should alarm everyone. You can go to the next slide, please. Data we receive from law enforcement allows us to conduct more in-depth analysis, as reflected on the next few slides. From our data, we have identified over 14,000 individuals who have been administered naloxone. In that data set, we found 15% repeat victims. You can go to the next slide, please. The rather large caveat I have to say here is that the number is skewed low due to the fact that our data is very limited, and this only represents people who were administered naloxone by law enforcement. Many more people receive naloxone from EMS, are treated at hospitals, or receive naloxone privately. It's very likely that at least some people who have been administered naloxone by law enforcement have also been administered naloxone elsewhere. This highlights the impact that substance use disorder can have on our population and the threat that dangerous synthetic drugs have. And there are sometimes disguised as legitimate prescription drugs as well. You can go to the next slide, please. Again, looking at our data, we've broken it down where we see most repeat victims and two distinctly different counties, both Monmouth and Camden, have had the most documented repeat victims. This is only based on law enforcement information, and as such could be more of an indication of local first responder response than actual incidents would indicate. So I just want to throw that caveat out there. Next slide, please. One other thing we do with the data that we processed is to understand which areas and demographics are most at risk. Looking at known repeat recipients, 43% of the recipients were 25 to 34 years of age. 78% of the repeat recipients were white, and 73% were male. Go to the next slide, please. So this is going to assess naloxone data in terms of COVID implications. We broke this data down into EMS and LE because the data sets are slightly different. When looking at the data, you can see it appears that people treated by EMS refused transport to the hospital more so from March to July than the rest of the year. You can go to the next slide, please. Law enforcement documented similar statistics. April and May were the two lowest months for victims being transported to the hospital. Why the last two slides are problematic is that people are more likely to receive additional treatment and resources from a hospital setting. So again, what we saw here with COVID, and when people were coming out of an overdose being revived by naloxone and they were refusing transport to the hospital, likely in fear of COVID, but also neglecting them from further treatment and resources that they would normally have access to. Again, just another impact of COVID on the drug environment. Next slide, please. So one data set that is very valuable to us is the treatment admissions data. And what you can see here is despite more drug-related deaths that we talked about a couple slides ago, unique clients and total admissions both declined significantly for the first time in the last 6 years. We're making that correlation to COVID, during 2020. Again, if there's the same impact or even a higher impact in terms of deaths, but less people are seeking treatment than ever before, or at least in the last 6 years, then that's, what is the reason for that? And we're attributing that to COVID and barriers to treatment and social distancing and all these other things. You can go to the next slide, please. Not surprisingly and consistent with the other data we've seen, it appears that COVID had a significant impact on treatment admissions in those who would normally seek help. Admissions slowed in March, and the lowest numbers we saw were in April and May. Again, that is 100% tracking with the onset of the pandemic in March, a lot of fear in social distancing protocols in April and May, and really just kind of hard for people to get the treatment that they needed. You can go to the next slide, please. The next few slides for our audience are not necessarily COVID-centric or related, and we'll kind of get back to that. However, they provide important context for the drug environment. In New Jersey, our forensic labs have increasingly and alarmingly identified fentanyl in packaging that would normally have contained heroin in the past. We first reported that this was going to happen in 2015 when fentanyl was only 2% of the suspected supply of heroin samples tested by forensic labs. Today, almost all powdered opioids being distributed contain a form of fentanyl. For those who may not be aware, fentanyl is exceptionally more potent than morphine or heroin, and as discussed, this poses an increased risk of overdose or death to anyone who may come into contact with these drugs. You can go to the next slide, please. Commensurately, kind of obviously, with fentanyl rising, the number of suspected heroin submissions testing positive for heroin steadily declined from 98% of the first quarter of 2015 to just 5% in the fourth quarter of 2020. It's obvious to state here, but heroin is becoming increasingly less prevalent, and fentanyl is really taking over the drug environment. Next slide, please. The other factor I want to call attention to is that methamphetamine continues to see a significant increase in presence in New Jersey. Specimens submitted to New Jersey State Police Forensic Labs topped 10,000 for the first time in 2020. So I'm going to cite some official sources here. According to drugabuse.gov, methamphetamine is a powerful, highly addictive stimulant that affects central nervous system. And from the Substance Abuse and Mental Health Services Administration, or SAMHSA, methamphetamine causes changes to the brain circuits that control reward, stress, decision-making, and impulse control, making it more difficult to stop using, even when it's having negative effects on your life and health. Frequent use can lead to tolerance and withdrawal, so you'll need more of the drug just to feel normal. Additional effects of using meth can include anxiety, depression, chronic fatigue, paranoid or delusional thinking, and serious psychological illness. Again, that's from SAMHSA. The significant increase in indicators of methamphetamine in New Jersey is something that should not be overlooked due to the overdose epidemic or the global COVID-19 pandemic. So again, we have two things going on here, but we're seeing tremendous increases in methamphetamine, and it's a highly addictive stimulant and something that we should be well aware of. Next slide, please. The last slide I'm going to present regarding our data has to do with the pills submitted to forensic labs for analysis. And the real dilemma here is that many of these pills being sold in the illicit drug market are thought to be legitimate prescription pills and therefore thought to be somewhat safe. While we do see a lot of legitimate prescription pills in our labs, we also see pills that are made to look like prescription drugs, but really contain fentanyl class compounds or other dangerous drugs. Somebody who has a tolerance for a prescription drug and is unknowingly ingesting considerably more potent drugs are at a higher risk for overdose or death. And we've seen too many cases of this where people thought they were taking a prescription oxycodone pill and were really getting fentanyl or even carfentanil, the really, really dangerous fentanyl analog. So you can move on to the last slide, please. In closing, we've been describing this past year in regards to the overdose epidemic as the perfect storm because of COVID-19. Nationally, drug-related overdose numbers continue to increase, and this is a CDC fact here. Suspected drug-related deaths have exceeded 80,000 from June 19 to May of 2020, with the highest months in the first half of 2020 at the onset of COVID-19. And that is similar to what we saw here in New Jersey when I showed you those statistics earlier. This new data on drug-related deaths in the context of the pandemic and really the disruption to the public health care has ignited a sense of urgency for essential services to be made accessible and incorporate an expanded undertaking of prevention and response. As we presented, drug-related deaths have increased during 2020, while people have increasingly refused hospital transport or further assistance, and treatment admissions decreased. The few things that I presented earlier, highlighting the impact that COVID-19 has had on those who need assistance and those who are suffering from substance use disorder. The overdose epidemic has not gone away and in many ways was worsened by the pandemic. And I want to thank everyone for tuning in and listening, and please reach out if I can be of any assistance. Thank you so much.
Thank you so much, Jason. That is a really informative presentation. I know that you were one of our very first speakers on our webinar series last spring, and to be able to see all of the changes that you've tracked in this year is so helpful and informative. So I appreciate you being with us here again today. I know there are a lot of questions in the chat about access to the lieutenant's presentation. As I mentioned at the beginning, that presentation will be made available to all of our attendees. And I know there's some other questions as well, and we'll get to those at the conclusion of all of our presentations. So now I'm going to turn it over to our next expert panelist, Dr. Fisher. Dr. Fisher, welcome. Dr. Fisher, are you with us?
Hey, my apologies. I was on mute talking to myself.
No worries, no worries.
It's hard to believe it still happens, but yep. Anyway, thank you for allowing me to be part of this presentation. And I think the presentation we just listened to really says a lot about the terrible impact that COVID-19 has had on everyone this year. And I'm not surprised that the addiction has increased. We also know that isolation, depression, and behavioral health problems have dramatically increased over the last year. But what I'm going to talk about is maybe some light at the end of the tunnel, and that's about the COVID-19 vaccine and the vaccine rollout. Next slide, please. I always start with this disclosure when I talk about COVID-19 or SARS-CoV-2, the virus that causes it. We know that information is really continuing to evolve daily. We get new information about variants, about this, about that, about the other thing, literally every day. And the recommendations change frequently. So what you're hearing from me today may be outdated by the end of today, by the end of the week, or by the end of the month. So I encourage you, go to these trusted sources to really get up-to-date information. And this includes the New Jersey Department of Health and the Centers for Disease Control and Prevention. Next slide, please. So just a few basics. I think we all know this is a real disease and it can be serious, but I want to mention that the disease from the SARS-CoV-2 can vary from no symptoms at all to a mild common cold-like illness, to pneumonia, infection in the lungs, to multiple organs being involved, to needing a respirator, to ending up in an intensive care unit, and even to death. We know that multi-system involvement and death are more common as people get older, but we also know that unfortunately young adults have suffered as well. The good news, I'm a pediatrician, so for me, the very good news has been that disease in children is almost always either asymptomatic, no symptoms at all, or very mild disease. We do have this strange illness called multi-system inflammatory response. It occurs about a month after a child gets the virus, and it's a complication of the inflammatory system, the immune system, and it's kind of an immune overreaction. Fortunately, this is treatable, and the vast majority of children will recover completely. Next slide, please. So this disease is caused by this virus, SARS-CoV-2, and we know that it's spread from person to person by droplets that we make as we talk, sneeze, cough, sing, or even as we're just breathing. Now, most of these droplets will fall to the ground within 6 feet, but some of them do occasionally stay airborne, and therefore you can have spread over longer distance, these so-called super spreader events. And what happens is the droplets can land into a person's eyes or be inhaled by a person who's standing close to you. Next slide, please. This is an illustration of a person sneezing, and I think it brilliantly shows you all those droplets. You can see most of them are falling to the ground within about an arm's length distance, but a few do go out further. And these are the way, if this person had COVID-19, there would be virus in all of those little droplets that could spread to the next person. Next slide, please. So how can we protect ourselves? Well, the first thing we want to do is we want to wear a mask. Why wear a mask? Because you prevent those droplets from going out into the world. Remember, you could be infected and not know it and be unintentionally spreading it. Also, what the mask does is it prevents you from inhaling those droplets. So the droplets are caught in the mask before they get into you. We want you to keep a physical distance away from other people, 6 feet if possible, whenever possible, and avoid crowds, because in crowds, you can't keep that distance and you're more likely to come into contact. We want you to wash your hands often, stay away from sick people, and stay home if you are sick. Don't go out and infect other people. And finally, as soon as you can, get vaccinated. Next slide, please. So what about these vaccines? We now have 3 vaccines that are authorized for use. We have 2 vaccines that are so-called messenger RNA vaccine, the Pfizer and the Moderna, and we have one that's an adenovector vaccine, that's the J&J or Janssen vaccine. Next slide, please. So the messenger RNA vaccines both require 2 doses, Pfizer after 3 weeks, Moderna after 4 weeks, and whatever you get the first time, you should get the same vaccine the second time. Next slide, please. So how do these actually work? Well, remember that the virus itself is not in the vaccine. It's just a little piece of information, a little code for the protein that's on the outside of the virus, that cranberry colored spike that's on the outside of the virus. And what that spike does is it allows the virus to actually infect you. So if you make antibody against that spike, then you will be protected against disease. So this little code is wrapped in a little bit of fat, a lipid nanoparticle. It goes into your body, and then within your body, the code is read by your cells. A little of that protein is made. Your body says, wait, that protein's not human protein. We better make it a defense against it. So it makes antibodies and cell-mediated immunity. And then when you're exposed to the virus, you are protected. Next slide, please. The J&J vaccine is similar. It again has that little bit of code, but this time, instead of putting in a little fat lipid nanoparticle, it's put into another virus. And that's an adenovirus that's particularly designed so that it can't make you sick. It can't replicate, it can't make more of adenovirus. But what the adenovirus does is it presents that little piece of code into your body, your cells read the code, and again, you make a response so that when you get exposed to the COVID-19 virus, you won't get sick. Next one, please. So how is it that these vaccines were developed so quickly? Well, what you need to know is that messenger RNA vaccines and adenovirus vaccines have been worked on for more than 10 years, more than 20 years. The adenovirus vectors were developed back in the 1990s, and the messenger RNA were developed when we had the first severe acute respiratory syndrome, or the first SARS outbreak back in 2003. So there was already that technology available. And then, because we really needed a vaccine quickly, what we did was have the companies overlap those trials. There's 3 phases that goes through to ensure it's safe, but they overlap them, and they started making vaccine right away so that it would be ready as soon as the vaccine was proven to be safe and effective. And for all vaccines, safety is primary. These are medicines that are given to people who are well, so we really have to make sure that they're safe. Next slide, please. So you should know that in all of the vaccine trials, there were people of different races, different ethnicities, different ages. Many of the people had underlying diseases. There were no head-to-head trials to see if is one vaccine better than the other. So nobody has compared Pfizer to Moderna or to J&J. And the vaccine trials were done at different times in different locations, and therefore you may come up with different numbers as to how effective the vaccine is. But again, no head-to-head trials. Good news, all 3 vaccines are very, more than 95% effective at preventing hospitalization and preventing death. All of these trials are ongoing for 2 years, so eventually we'll know how long that protection lasts. Next slide, please. So what are the side effects? Well, whenever you get a shot, you're going to have pain at that injection site. That's common. In addition to that, fatigue, achy, headache, these are common side effects after all vaccines. And really what they are is a sign that your immune system is working and is starting to protect you. So those are very common and usually don't last more than 24 to 48 hours. A risk for severe reaction is way less than 0.5%. Now, we do know that for the Moderna and the Pfizer vaccine, people who have a history of anaphylaxis, a severe allergic reaction to medicines or to other vaccines, you should talk to your doctor before you get the vaccine, and you should let the people at the site know that, and they will watch you for additional time after you get the vaccine. It's also nice to know that side effects are less common in people over 50, but unfortunately more common after the second dose. Next slide, please. So how do we roll out the vaccine in New Jersey? Well, our goal is to vaccinate at least 70% of the adult population, or really everybody who wants to be vaccinated. We started with frontline workers, and that started on December 18th. Why? Because those are the people who are taking care of people who are sick, and we need them to be protected. We also included people who live in group settings, like nursing homes, skilled nursing facilities, group homes, and jails, because those people can't really isolate themselves or stay apart. Next slide. Now, we rapidly increased who could get vaccinated. So by January 7th, the vaccine was available for first responders, law enforcement, and fire professionals. By the middle of January, everybody over 65 years of age and also people between 16 and 64 years of age with these health conditions. Why did we pick this group? Because these are the people most likely to get sick and die of COVID-19. So we wanted to prevent that from happening. Next slide. As of last week, we rolled the vaccine out to educators and everyone who works in schools, all of the school staff, and also childcare workers. And then just this week, we rolled the vaccine out to transportation workers, public safety workers, migrant farm, tribal communities, homeless, and those living in any kind of shelters, and in people with additional health conditions that might put them at higher risk if they get COVID-19. Next slide, please. So at the end of this month, we will roll it out even further. And you can see on this list, we're now rolling it out to most of the adults who are in New Jersey. Eventually, and the president says by the beginning of May, we want this vaccine to be available to everyone who wants it. Next slide. So how do you get the vaccine? Well, the first thing we want you to do is register. You can do that at this website, covidvaccine.nj.gov. And this is a secure portal that gets you the ability to register and then in many cases to schedule the vaccine. If you don't have a computer or you need assistance, there's a call number there, 855-568-0545 for people to call, and that call center can help you get registered. There's also a special call number for seniors, and that number is 856-249-7007. So for people who are having trouble registering, we have the call center. Next slide, please. So what information do we need? We get this information so that we can tell whether you're eligible or not. So we need to know your name, where you live. We collect information on gender and race to be sure that we're having an equitable rollout of the vaccine. We want all of our high-risk people to get vaccinated, and we need to know who's getting vaccinated. We ask for medical questions and for your occupation, and it's important to remember all this information is for public health purposes. It's not released to the federal government or to anybody else. It stays within public health to figure out if you're eligible and to make sure that you get a second dose if you need it. Next slide, please. So what do I want you all to do? Please go tell someone why this disease needs to be taken seriously. Now is not the time to roll out our vigilance. We need to continue to wear the mask, keep that distance, etc. We want you to tell people that this disease can be prevented, that the vaccines are safe and effective, and they prevent you from getting sick. We want you to know that everyone over 16 who lives, works, or goes to school in New Jersey will eventually be able to get the vaccine as soon as we have enough vaccine. And you can get this vaccine whether you have insurance or not, whether you're documented or not. Everybody can get this vaccine. So those are the facts that we want you to know, and go tell someone else. Next slide, please. Thank you.
Thank you, Doctor. I think that was really important information, and I know it's of significant importance to many of our attendees who work in residential treatment facilities, as well as anyone else who is working with the out in the population. So appreciate that information. Now I'm going to turn the presentation over to our next panelists. They're going to present together. They are the co-directors of the New Jersey Harm Reduction Coalition. So now I welcome Caitlin O'Neill and Jenna Miller. Welcome.
Hi, everyone. Hope you're having a great morning and staying dry, and honored to be here with you all. So my name is Jenna Miller, she, her, co-director of the New Jersey Harm Reduction Coalition. And I wanted to give you what you're going to be hearing today is you're going to get an overview of what we're working on and what our COVID response strategy is. And then the 3 lessons that we learned from this work are that it has reinforced what that people who use drugs are facing barriers to access for naloxone and safer use supplies. We learned that people who use drugs save lives and improve public health when we have access to these supplies. And we also learned that drug use is an issue of public health, not criminal justice. And so when we think about the perfect storm, what are policies that we can change for drug policy and moving it out of a punitive system and into a public health system that really can help reduce some of the dangers of the storm. And I am honored to be here today with my co-director, Caitlin, who will introduce herself now.
Yeah, hi, thanks, Jenna, and glad to be here today. My name is Caitlin O'Neill, and as you've heard, I'm the director of harm reduction services at New Jersey Harm Reduction Coalition. And so, yeah, we're here to talk to you about some of the things that we know for statistics and some of the things that we see on a daily basis with the participants in our programs and the people who reach out to us from across the state.
Next, please. So this is an overview of what we do. We're going to be focusing today on the parts in yellow, so naloxone distribution. And to give you a sense of harm reduction, we can look at vaccine rollouts, right? So we've learned from vaccine rollouts that we want to meet people where they're at. Where are people regularly going? Do people have phone access? Do people have internet access? Who do people trust in their communities? And this is exactly what harm reduction thinks about when we're getting supplies and support to people. We think about and use the power of peer networks. And one of the things that our amazing physician ally talks about is that even though peer networks are who can reduce overdose deaths and connect people to care the best and the most effectively, we also continue to shun peer networks in our legal system and through our arrest system. So this gives you a sense of our organizational overview, and hopefully that gives you a little bit of background about harm reduction's philosophy and approach. Okay, next, please. So Caitlin can speak to this as our amazing director of harm reduction services.
Yeah, so one of our organizational priorities is really meeting people where they're at. And we do that through direct distribution of supplies and through partnerships with people who we know are, so to speak, on the ground or, actually maybe engaging in some of the things that we talk about, like drug use or people who are in recovery. And we also do direct mailing services and community outreach. So we mail overdose prevention supplies, including naloxone, which you sometimes hear referred to as Narcan, which is the brand name. And that's the medication that reduces an opioid overdose. You heard some people speaking about it earlier. So we do that. Like I said, we mail that for free throughout the state. And we also do direct community outreach, which during COVID has been a little risky throughout the state, but we stay local to our local areas so as not to be, putting other people at high risks. And through that work, last year, we started in March when we saw the need. And as people spoke about earlier, the compounded risk factors that people who use drugs in the state are facing as far as isolation, limited services, or hesitance to seek services with the pandemic. So we began mailing and increased distribution of naloxone last year in March. And from March to December of 2020, we distributed over 6,000 doses of naloxone throughout the state. And those went directly to people who requested them and took a simple training from us. We have a variety of different low barrier partnerships. We have a prescribing physician who prescribes naloxone for our organization under the state standing order. Anyone who trains to use it is able to use it. And we know that families who have a family member who is using drugs and at a high risk of overdose, having naloxone in the home, sometimes that family member will be the first responder before an outside responder comes. So that does a couple things. And we also know that 9 out of 10 times that family member or the person who uses drugs, people who use drugs themselves, are first responders. And that takes a little bit of pressure off of the emergency first responders in our state, especially during the pandemic, while resources have been needed throughout the state. And as we saw earlier, not as many people might be calling 911 or be hesitant to go to a hospital. Having naloxone directly in the hands of people who we know 100% are either living with or hanging out with or working with or in meetings with people who are using drugs, that automatically puts them as like within seconds, they are able to administer naloxone if they see an overdose.
Next, please. So we have seen through this work, we scaled it very rapidly when COVID was happening, and are very grateful to our many partners who made this possible, some of whom are probably on this call right now. So if you're listening to this, thank you. We have requests from every corner of the state. So sometimes we hear from people saying, well, this is available in my community. And what we are saying and advocating for and doing is this available as low barrier as possible? Can someone get as many doses as they want? Can they give it to their friends? Is a training 2 minutes, 10 minutes? Is it something people can get to? And do people not only know where supplies are available, but can they get to those places? Or can the supplies get to them? And then we use that we think about free naloxone day, right? Which is this great option to get naloxone out through pharmacies. And then in our work, we've seen all of the people that can leave behind, because not everyone can get to a pharmacy. Not everyone feels safe going to a pharmacy. And our motto is we need every day to be free naloxone day. We also saw that, and this is a budgetary calculation, that the state spends dramatically more on arresting people for drug use than access to treatment. And so that's something that we know is important and are going to be continued to advocate for more of. Next slide, please. And Caitlin can speak to this, but we just consistently hear from people about how difficult it is to access existing programs, and it is our job to reduce as many barriers as possible.
Yeah, so these are just a few of the quotes from people who have used our services as to why they use our services. And some of them are something like they don't have insurance or even identification. And to get naloxone from a pharmacy or sometimes from different programs, they are required to use their insurance. The cost of naloxone can be upwards of $140 in a pharmacy. So that doesn't make it necessarily a low barrier access for everybody. So some people have also told us that they've looked for it in pharmacies in their area and they don't have it, or they don't have an order of it coming in. People also have spoken, actually, I would say that is one of the main things that we hear, that the pharmacy either is out of it or doesn't have it. And, during this global pandemic, all hands on deck for fighting the COVID-19 pandemic, we don't want to lose the resources that need to exist for what is already a public health emergency for people who are at a high risk of overdose. And some people just say there aren't any community-based organizations near them, or that they don't have transportation to get to them. So mailing and having the option of delivery or in-person outreach when it's a little safer, or even just a pop-up event in a parking lot like we do sometimes when the pandemic wasn't here. Having those options allow people to get naloxone directly without worrying about how they're going to get there, without worrying about whether they can afford it, and without worrying about whether they will face stigma or judgment for saying that they are somebody who is at risk of an overdose or at risk of seeing someone they know overdose. And so one thing, Jenna, do you want to go next?
Yeah, I think, but no, can you finish your thought? One thing.
No, that's fine.
Next slide, please.
So with the outreach that we were speaking about, one of the things, like we said, we know that people who use drugs are first responders. We know the community members reverse overdoses when they have access to naloxone. We've had over 50 overdose reversals reported from the naloxone we've distributed. And we know that number is a little underreported just because not everyone is going to call our phone line and let us know that they've used it. But we speak to some community responders who have reverse upwards of 10 overdoses just among their friends because it's something that they're seeing and it's happening. So we know that this is a life-saving medication and that it shouldn't only be available in certain places. It should be available statewide at a very low barrier or no barrier. The training is super simple. And once people have the resources, we know that they use them. We know that people who use drugs want to take care of each other and have a sense of community. We know that there is just a lack of resources and knowing really what to do. And the community leaders that we partner with keep supplies on hand. They share information. They train the people that they give their supplies to. And they're people who, like we said, might not walk into a pharmacy, might not be comfortable calling a request line, might not be comfortable asking for naloxone at a recovery program or saying that they are at risk for this. And one of the things that we also do is really identify and invest in the leadership of the community residents that we work with a race equity lens. Overdose rates in New Jersey are growing fastest among Black and Latinx residents. So one of the things that is absolutely essential right now is making sure that Black and Latinx communities of New Jersey have free access to life-saving supplies.
Next, please. So decoupling arrest from drug use and drug policy is not only practical, it's also moral. And the reason that it's practical is because the research shows that the only time that trying to interdict supply is really effective at promoting public health is when a drug is very, very new, introduced to a market. That ship has sailed a very long time ago for fentanyl, and many people believe that fentanyl is here to stay. We also know that drug arrests, while some people might describe a drug arrest as connecting them to resources, for the vast majority of people promote a vicious cycle rather than a virtuous cycle. So disconnecting from housing. We hear from folks who get their naloxone taken away from them when they are arrested. It alienates people from their families. It makes people ineligible for public benefits. And it's resources that we could be putting into investing in people's health and well-being. And so we also see that harm reduction services are not available in the vast majority of New Jersey's municipalities because of the restrictive laws that limit harm reduction centers. So that is something that we are seeing through COVID, is where people are identifying these barriers. And a lot of them are in public policies that aren't centered in the health and well-being of people who use drugs. And we believe and see every day and know from many of you on this call that that is your priority. And so we're excited to work together to shift that. And Caitlin has a really important framing to understand why harm reduction is an essential part of the continuum of care for residents who use drugs.
So I'm not sure which framing you're referring to because I have several, but definitely if we think about the fact that it is a fact that any given time when people are seeking services through harm reduction or through arrests or through anything, if they're asked, 9 out of 10 people are not interested in treatment at any given time. That means that the 1% who have options that exist in the state, but that 90% of people who are currently using drugs in New Jersey don't have any system of support if they're not interested in treatment. We know that that's not a permanent thing, that things can change and people can change their minds. But in that moment, 90% of drug users in our state are without supports if we don't provide harm reduction support for them. So really this is a very low level of life-saving support and public health that we can utilize to keep people alive during this time.
And we also know that for people living with a substance use disorder, return to use is a common and expected symptom. And by treating that symptom as a violation of criminal legal system and something that you can be arrested for, we're also, when we say what can we do to destigmatize, to really end stigma, at the same time, our laws are enforcing stigma. So that's why we are advocating for them to change. And next and last, because I know we're at the end of our time, please keep in touch. Please share with people how to get these resources. Please join our efforts to expand harm reduction. And we have a bi-weekly virtual naloxone training that we encourage you to sign up for and share with others. And then concluding thoughts from Caitlin, who is doing the work every day. And I just, on a personal note to everyone, I want to say I feel very lucky to partner with her.
Thanks, Jenna. I feel the same. And yeah, just like the one thing that we remember is that, like, as we've heard a lot throughout this pandemic, like, we're all in this together. Like, that absolutely applies for the overdose epidemic. The health of one New Jerseyan is equal to the health of all New Jerseyans. So when we look at this from a public health lens, to offer some support and basic dignified healthcare to people, we allow them to make whatever they see as the next positive change. When we offer a compassionate care and a trauma-informed lens to people who are facing substance use disorder, we open a host of opportunities for them. So we really believe in expanding harm reduction, working together, and preventing fatal overdoses, and just getting supplies to whoever needs them. And
All right,
we really
great.
appreciate it.
Thanks so much for sharing that information with us. I know we have some questions. I also know we're coming to the end of our time, so we may not be able to get to all of your questions. If that's the case, when you get your email with your links to the presentation from today, please feel free to respond with any question you have, and we can try to get it to the panelists. But Dr. Fisher, I'm actually going to go to you first, because our chat is kind of blowing up with requests for that contact number that you provided for seniors specifically to address or to get an appointment for a vaccine. So I'm not sure if you can share again any phone numbers or websites that you mentioned. You shared some information in the chat, but to just bring that back to you again so you can confirm the best strategies.
Sure. So actually starting today, this is why no one knew about this number. It just started today. We have expanded our outreach to people 65 and older, and we have established a seniors call-in number for those people. That call-in number, and this is just for seniors 65 and above, 856-249-7007. Now, there's also a number, a general call-in number for people who aren't very good with computers or just have questions about the vaccines. And that number is 855-568-0545. And then if you go to the website for the Department of Health in New Jersey, there's a COVID hub, and you can get all kinds of information from that that's updated literally every day.
Great, thank you so much. And once again, we will be sharing a recording of this presentation, and we will be sharing all of the slides. So you will be able to go back and refer to anything that was mentioned. Again, I know we're coming to the end of our time, so we're going to go ahead and start putting up our poll. If you could give us some feedback on today's presentation while we continue our question and answer portion, I would appreciate it. And Jason, I'm actually going to go back to you. There's been some questions in the chat, just if you could really talk about the differences between heroin and fentanyl, particularly on potency and on price. And I know that's a big question, but if you could try to address that briefly.
Sure. So when I mentioned earlier in the presentation, we first forecasted the fentanyl would be an issue in 2015, and that was because of the economics of it. And to give some context to it, a kilo of heroin, a street value kilo of heroin would be $60,000 to $80,000. Whereas at the time, you could have procured a kilo of fentanyl for $3,000 to $5,000. A very, very large difference in price, obviously, but that's only part of the story, because fentanyl is 20 to 40 times more potent than heroin. So for that $3,000 to $5,000 investment, you're getting 20 to 40 times as much of the doses that you're going to put out and distribute. So the economics of it just made it very clear to us that this was coming, and this was it was going to overtake heroin. And further, the cultivation of heroin takes a lot of effort and work and trafficking, and the fentanyl production is, you know, a synthetic opioid is much easier as well. So there were a lot of factors into it, but it is, again, a lot cheaper, a lot easier to produce, and gives a lot more product in the end for people who are distributing.
All right, thank you for clarifying that, giving that additional information. Jenna and Caitlin, I have a question for you. You spoke about how Narcan saves lives. How would you say Narcan distribution days that were held prior to the pandemic may have helped save lives from overdose during the pandemic? And also, two-part question. You noted, I think Jason noted about Monmouth County having one of the highest rates of overdoses and one of the lowest, and you guys noted that it has one of the lowest rates of Narcan distribution. So could you speak a little bit about barriers that would prevent saving lives? I know it's a big question, but
no, that's
sorry.
Jenna. So I would say that with free naloxone day, that is definitely a boost. But we know that the fact that it's just available in pharmacies is a limit for people, because they have to be able to get to the pharmacy. It has to be a pharmacy that's participating, and they also have to be comfortable asking for it. So for example, you know, if someone is like in a local pharmacy and the pharmacist is their neighbor or their teacher or their son's friend's mom or something like that, they might not be comfortable asking for it. So, you know, one of the things that we talked about reducing stigma is huge, but also free naloxone should be available everywhere, all of the time. If that, or that's what is needed if we're going to make a significant make a significant dent in the overdoses. But Jenna, you go. Sorry.
There's 3 FDA approved forms of naloxone, and we advocate for all 3 being distributed, because there can be, we are going to have to invest millions and millions of dollars in the purchase of naloxone itself. And we need to make sure that naloxone isn't sitting behind closed doors, isn't on shelves, and isn't going only to people who and by we, I mean the global we, like in making policies and designing programs, think are like quote unquote responsible. Like, can I come to a Zoom training? Can I register? Do I show up for that Zoom training? Am I going out of my way to get this? We need to have an assertive, proactive approach to make sure that people are getting naloxone. So something that we are trying to do, that they're doing in Ohio, is looking at where the overdose death rates are highest by zip code, and then partnering with local community organizations. So that's mutual aid groups, recovery groups, churches, places where people are going every day to reach people where they're at, and not have naloxone be siloed in only, it's like, yes, and we need naloxone everywhere. And then just want to make clear that naloxone is not an incentive to use more. It actually feels very terrible to have an overdose reverse. It's unpleasant, and people have no incentive to, naloxone does not increase drug use. And actually, harm reduction programs are shown to be 5 times more likely to connect people to a substance use treatment that works for them. And people who have access to harm reduction services are 3 times more likely to reduce or stop their chaotic substance use altogether.
All right, thank you so much. Thank you so much to all of our panelists. I know we are at the end of our time, and that many of you have to jump off for other events. I do want to mention that we the next webinar in our Knockout Opiate Abuse Day learning series will be on Thursday, April 22nd. It will feature Dr. Andrew Kolodny, who will be speaking about the national perspective of the opioid crisis during the COVID-19 pandemic. So that's Dr. Andrew Kolodny, 1 year later, the opiate epidemic during COVID-19. And you can sign up for that at knockoutday.drugfreend.org/register to get the information on that. We'll also include that in the email that we send out to you. Again, I know that we had a lot of questions that we weren't able to get to, but please feel free to respond to the email that you receive with the the link to the presentation and the slides, and we'll do our best to try to get those answers to you. Again, I want to thank all of our attendees today. I want to thank all of our panelists for your time and your prep for this, as well as sharing your information, and just everyone for all of the work that you've been doing during this past year, addressing this epidemic, this addiction crisis, all with the added pressures of saving lives from COVID-19. So I thank everyone again for being with us today, and I wish you well. Have a good day.